Hi there, everybody. Welcome to the ToRAISE Questions Doula podcast. I'm Melanie Headley. I'm a 2-labor certified professional birth doula, and I'm here with ToRAISE Hakoun, the executive director of 2-labor, which is an international doula training and certifying program. Hi, ToRAISE.
Hey, Melanie. How are you?
I'm good.
Yeah?
Yeah.
Keeping busy?
Yes, very busy. Lots of balls in the air.
If you guys knew Melanie like I know Melanie and have known Melanie for a long, long time and her other mother besides her friend, you would not believe the balls she has in the air.
I like the pause,
Yes.
though.
And somehow I just relate to it, and I want to punish you. I want to say, stop it. And I think, why? Nobody stopped you. As long as you stay healthy, that's what I care about, is because I know it can be stressful holding those balls in the air.
Yeah.
So just be careful.
Thank you. Thanks, Mom.
Yeah.
Well, we'd also like to thank those of you who have listened to our pleas for donations. We really appreciate it. And we've got some names in our hat right now, and we are really excited. And so please keep donating. We appreciate it.
Yes. And don't forget, we do have a drawing for Thanksgiving.
Yes, the drawing is set for Thanksgiving, and those of you who are willing and able to donate $100 or more, your name will go into this drawing to receive a one-on-one consult with ToRAISE over the phone. And then those of you who are willing and able to donate $50 or $50 to $99, I guess we can say, your names are going into a hat to receive a 2-labor tote bag.
Mm-hmm. Yes. And yes, thank you. And you've heard us before, or if this is your first time listening, the donate button is on our website, on the tab section all the way to the bottom. It says donate. It'll take you to that page. Or if you go on the front page of the website, is a link to the podcast, and there's a donate button right there at the podcast icon as well. So thank you, though, everyone who's been helping us. It really does make a difference, and we appreciate it. Not to be overwhelming you, but it really is beneficial to help us keep doing this.
And those donations bring us to being able to record and also have amazing speakers like we do today.
Yeah, today I'm really excited to maybe introduce to some of you, and maybe for some you already know of this woman, but we are going to have here in the studio our a guest, Jennie Joesph, who is a licensed midwife, a certified professional midwife in the Orlando, Florida area. She's a phenomenal woman. In every way. I mean, I just really think the world of her without sounding like I'm, an adoring fan. I am an adoring fan, actually, and I don't believe in putting people on pedestals, but
it's hard not to.
Well, she belongs on her own pedestal of what she speaks to, and her actions are not just speaking. She doesn't just speak, she acts.
And she inspires.
Yeah, she does. And so we will be talking to her about racial disparities in maternal health care and what we can do and so forth. But I'll let her do the talking. So stay tuned.
And we also get to hear from Peggy Caster.
Right, who is Executive Director of Birth Matters Virginia, which helps bring her here. And I just have to put a plug in for Birth Matters. It is a wonderful organization that was a grassroots organization that began by a group of moms many years ago, over a decade ago, here in Virginia. And I had the honor and privilege of being executive director of Birth Matters at one time, and really saw the benefit of the organization. So there'll be information from Peggy about how to understand better what that organization looks like. So stay tuned, and we'll talk to you soon. we're here with Jennie Joesph from Common Sense Childbirth. Welcome, Jennie.
Thank you.
And we also are here with Peggy Keister from Birth Matters Virginia. And I want to thank you, Peggy, for being here, because you are the reason, your organization, Birth Matters Virginia, is the reason that we have the opportunity to speak with Jennie one-on-one and have listened to her for the last couple of days. So thanks for being here.
Thanks, ToRAISE.
So just for a moment, can you tell us a little bit about Birth Matters Virginia?
Sure. Birth Matters is a 10-year-old statewide organization with about 100 members, and we are thrilled to have brought Jennie to Virginia to help break down barriers for women from all backgrounds to have evidence-based maternity care. And bringing Jennie to Virginia is a first step for Birth Matters in raising awareness about the lack of quality maternity care that's not equally accessible for all people in our community and throughout our state. So we're thrilled to have made this leap and to have been able to listen to Jennie's wisdom, and we look forward to more work and more relationships.
Great. And if people want more information, especially those who live in Virginia, but even for those people who live outside of Virginia who are interested in creating a nonprofit like you all have have in existence, they can. You have a website.
We do, yes. They can find out more information about us and the resources and our members at birthmatters.us.
Okay.
Yeah.
Great. Well, thanks.
Sure. Thanks, ToRAISE.
So, Jennie.
Yes.
So great to see you.
Same here. Thank you for having me.
So I think what would be, some people know who you are, have known about you for years, and many people really don't know what who you are and what you do. But so I'd like to give you an opportunity, I think, first, just to tell us a little bit about yourself, like who you are. Are you,
Absolutely.
What's your personal background?
Wow, yes, thank you for that opportunity. I've been a midwife since I was 19 years old.
Wow.
A student at least, and so I'm going into 36 years in the field, and I love it. I knew at 16 that I wanted to do this work. I was called, but I didn't really get it, And so I was in England. I was born and raised in England. My family are from the West Indies, and they immigrated to the UK in the 50s. And we were all born, raised, educated, and my family still live in England. I actually came to the United States, to Disney World, seriously. And I met my future husband on that trip. I was a single mom with a 2-year-old in tow. So he came to England and proposed, and I came back. And I know, and I've been here since. So that was 1989. And in the whirlwind of the long-distance romance and all the rest, I went with, well, he speaks English, I speak English, we'll be good. Let me just pick up my child and off I go. So I duly arrived in Orlando. I've been there ever since. And a serious wake-up call. Because in my midwifery journey, I chose to be a non-nurse midwife, direct entry midwife, which was very normal in Europe. And I had no clue that, one, there wouldn't be work for me as a midwife, because I expected to apply to the local hospital and just get on with it. I knew people had babies in America. But I also didn't realize the history and the connotations of midwifery. So not having a nurse separate degree as an RN, I was a registered midwife. There was a lot of consternation immediately about, well, we can't hire you. And what do you mean? What? Oh, no, we don't do that. And it was very, very shocking. I was really lost. That sent me into a bit of a depression, and I was overwhelmed. I also had all the reaction to, well, this accent, and it was just very different. And I'm a woman of color. I'm a black woman with a British accent in Florida.
Yeah.
And it was a big transition. But what I did do was I started working with an OB physician as really technically I was a medical assistant, although I didn't understand that at the time. I didn't even understand licensing. And so I was working for him, and it was through a course of unhappy gynecological events where I foolishly asked the same doctor that was my employer to support me with the issues I was having. I ended up in a really desperate situation and ended up having to undergo surgery at age 30 and really succumb to what was really essentially complete removal of all of my reproductive organs, and ended up with hysterectomy and so on. Wow. But what was particularly galling for me was in the understanding of how I got there. It was really quick. I had no explanations that made any sense. I got caught up. My husband was very upset with everything. And it was after it was done that I really kind of woke up and I realized what happened. I was blindsided. That's what sent me back to midwifery, because at that point I thought I would never practice anymore because I couldn't find a way. But it was that set me off, because I began to do the research. I looked into how did we get to this? The same physician that I worked for, a Caucasian, a Canadian, he was consistently booking women of color for tubal ligations, hysterectomies, myomectomies, taking out their fibroids, just any kind of something that was, as I learned, was billable. I began to see the correlation between medicine and money and commerce, capitalism, racism, sexism. It was very deep, and all at once.
You saw it more with African American
I saw it very
women.
clearly. If the woman presented for the visit that day, the first question was, "Are you still having your period?" Yes. "Is it painful?" "Yes, doctor." "Okay, Linda, get the book." Call down the hallway, and the surgery would be booked.
Wow.
Yes, ma'am. So I lived it, I saw it, I worked with it, and I was a victim myself by the time I was finished. And so I said, well, I'm going back to midwifery. And of course, at that point, I had to become the entrepreneurial midwife, which is often the way, right? Just like the entrepreneurial doula, where you have to create a practice. And so I started doing home birth, which I loved. I didn't know I would love home birth. I'd been a hospital midwife, and albeit a direct entry hospital midwife. But I loved home birth and enjoyed that for a few years. And then I realized, well, hold on, where are other people from different races, different backgrounds, different ethnicities? It was a very homogenous practice. Everybody was very middle class, very affluent. They were comfortable, they were educated, they were supported, they were in charge. And I was like, this is great, but it's not working. And then it was also very clear to me that the people that were having very poor birth outcomes had no access not only to midwifery level care, but what looked to be very poor quality care was all that there was available to them. And again, tying that back to my own experience, I said, well, something has to be done. And I took on then, let me see if I can find a way to bring women into the practice so I can at least give them a different quality of care and a different experience. And that led into what I now call the Easy Access Clinic. It didn't have a name back then. It was simply letting women start with me, but letting go of having to deliver their baby, because they didn't want the baby delivered at home. They didn't want the baby delivered in any birth center environment. They wanted to be in the hospital. And so I worked through that piece in terms of understanding, listen, wherever you have this baby, if you have a full-term baby and it's healthy and you're thriving and you're breastfeeding, I'll take it. And in the letting go of all of that midwife oxytocin thing, I got to a place of understanding.
Which I think our listeners really relate to.
I think they do, because we get very caught up.
Yes.
I mean, I get sky high and I miss the birth room, but it wasn't worth my stuff getting in the middle of an outcome, which the continual, decades-long records of horrendous outcomes, regionally, locally, by race, that there was no question there was something very
Can you give an
example going on there
of those statistics?
Yes. So you can count since those days, back in the 90s, even to this day, at an average, at least twice as many Black women are going to succumb to some type of maternal health issue. At least twice as many Black babies are going to be born prematurely or low birth weight. And then at risk of dying within the first year. So a minimum twice, by two, sometimes three, sometimes four times as many.
And are you speaking of throughout the country or just in your county?
Throughout the country. Throughout the country.
Right.
Now, when you go individual county by county, state by state, that's when you begin to see the 3 to 4 times.
Right.
Now, interestingly enough, the worst states of all are all in the South.
Yeah, and we've discussed this. Why do you see that as...
The connection is immediate to racism. And racism, poverty by way of racism.
Mm-hmm.
So class is part of it too. Social status is part of it. But in this instance, if you take an entire region of a country and these statistics stand no matter what, with many interventions, I mean, people have made gargantuan efforts to address these issues. And for some reason, they keep getting stuck. And there may be a drop here and a drop there, a few points, but there is no elimination.
Right.
There is no total, just eradication of these statistics. So if you take it from another angle, let's just look at it from this point of view. The pigmentation level in your skin dictates the type of birth experience that you can expect and anticipate. Then that's another way of looking at this issue. A third way would be if you were not of color and you just by the color of your skin were likely to have a better chance, then you'd have that same sort of response to, well, hold on, how is that?
Mm-hmm.
The question has to be asked, how is that?
Right.
How can that stand? How do we allow this to continue? If it were another country that we were talking about, in any other country, it doesn't even have to be an underdeveloped country, we would run headlong with all kinds of solutions.
Try to rescue.
We would be right there. The best brains, the consulting, the on-the-ground deployment of willing volunteers and committed staff would be right there, because it would be unconscionable and we would have a hard time accepting that it could be so.
And I think you hit that right on. I've seen that in other issues
Yes.
other than maternal care and infant care. Why?
Why? And so it's a hard one to look at. We tend to not want to look at it because we don't want to think about the answer.
Mm-hmm.
We have to accept, I think, in America that our cognitive dissonance allows us to keep denying to ourselves and each other and supporting our bigger institutions to not have to head-on confront that. And as long as we could talk about education, or we could talk about criminal justice, or we could talk about any number of other arenas. But where racism permeates, there you see the outcome. And so to dismantle that is the job. So we don't often want to ask that question because the dismantling is hard.
Yeah.
Where do we start? We get caught up. The guilt overwhelms us. People think we're talking about personally mediated racism and bias. Most of the time it's institutional.
Right.
It's not to say that that doesn't exist on a personal level. But when the institution continues to condone and support policies, practices, procedures, training, employment, anything where the institutional behavior is continued and is condoned and supported, then individuals haven't got a place to begin any kind of work. So culturally, it's across the higher levels, the higher policies, the political side of what we're doing. So let's take housing, for example. If you purposely set out to build substandard housing in certain areas, if you place housing developments next to environmentally unsafe areas on purpose, these kinds of things are indicative of institutionalized racism.
Right.
Institutionalized classism, like
That's
a certain caliber of person has to live here because we certainly don't want them living here.
Right.
Gentrification is another example. Well, now we need some more space to build some more lovely apartments or some more shops, and we'll go back to where we didn't want to be, where we left previously a few decades ago, and we'll come back in now because we need the land. So let's displace. We have like this arena thing going on in Orlando, lots of arena building going on,
What is that?
Sports arenas.
Oh.
Which are always in the downtown areas.
Right.
So people get displaced.
Right.
With no provision. Not much anyway. So this is historical behavior. This is normal behavior, really.
To a place where it is so subtle. I know it's very blatant.
It can be very blatant.
Yes, but it's so subtle because of it's just ingrained into the process.
The process. So, we look back in the 50s, 60s civil rights times, and we see a little more clearly because there was movements making it clear, bringing it forward. The Civil Rights Act was passed to address the issues that were raised, but the implementation didn't necessarily follow. So what you have is you just have newer iterations of the same issue.
We think it was implemented, though. I mean, you know what I'm saying?
Yes and no.
I mean, I think people have an illusion that these things have been implemented because people talk about, well, things are different now.
And that's part of our cognitive dissonance.
That's it.
We encourage each other with that. Mm-hmm. Yes, it's true. No, it's not. It's not true. And if you think it through a little bit, you immediately can see that. Because then we have the fabric of our society and ability to, we all joke around about, oh, Siri got me lost in the wrong neighborhood and I was out of there so fast. Of course, because you know what's in the wrong neighborhood and you know not to be there.
Right.
And you know you're not going to have to be there. And you know you don't belong there. And you know your children aren't going to have to deal with because we have it set that way.
That's right.
And we accept that.
Yep.
So if you say bad neighborhood, which in English language, what does that really mean? But everybody knows what it means. In America, there's a connotation.
I agree.
Yeah.
So that same bad neighborhood is what's killing our children. All of our children. We only have bad maternity care because it's acceptable to behave this way with a certain segment of maternity patients. And that's where all of these bad practices, these interventions were born. They didn't exist in abstract. They came from, we got away with this level, and so we'll move it up a tad or maybe a couple of extra steps higher for the rest of, the mainstream, who actually right now are not any longer mainstream.
Right.
People of color is going to be a majority country very soon. But the perpetuation of interventions and aggravations and pure wickedness in some cases on women during pregnancy and childbirth stem from what was done to women, women of color.
And then
the only reason it exists at all. Mm-hmm.
And then it became part of just the practice.
It's now normal practice.
Right.
So the same fight that we have in the birth world about changing that.
Right.
We're all committed to changing that. Doulas, midwives, lactation consultants, we all exist to change that. We all agree that there's a problem.
Right.
Those of us in the work.
Uh-huh.
The consumer may not realize.
No,
we're
that's
all
our
about
job.
educating the consumer to know that.
Exactly.
But if we just all disappeared,
It would
and
just
the system
go on.
continued, the consumer would not have access to education and understanding and wouldn't ask for anything different or know their options or be empowered. They would continue on. So we exist because we have a passion for, an interest in, we're affronted by. But we have had to grow and build and lay years and decades, before we get our message across.
Yep.
Bring up the youth and hope that they will carry on.
Exactly.
Pray for generational work to have some impact one day, someday.
Right.
That's birthy world.
Right.
But we're talking about something that is impacting an entire race of people in this entire country because the country started out that way.
Yeah, so it's not it's just the way it's always been.
Well, that's right. We've got Native American
The roots
people
are deeper than deep.
That's right. And so we're just all of us at our wits' end and we throw our hands up. And so it's so much easier to not deal because what on earth are we going to do with this stinking mess? So where we can, we go forward with what little can be done is worth having because without that little, there's no hope. None. This is not a new issue. Disparities in birth outcomes is not a new issue.
Right.
Now
I've been around a long time.
Yes.
And it's been always there.
It's always been there.
Always.
Yes.
Well, I mean, once I became aware, which was when I was a young woman, which was a long time ago, it I haven't seen anything change.
Right. So there's not necessarily a political will to change this piece. We're very interested in women's health, families' health, but in the bigger spectrum, that's one piece of a very large puzzle. So when we talk about how the social determinants of health impact women's health around race and poverty, we know that that's what needs to be dismantled as well. Can't just stay with the pregnancy piece or the birthing piece. She's going home and she's going to come from another layer of discrimination.
Yes.
And then her children are going to be born and inherit what is deeply in place. So, this is why you don't have the same outcomes, say, for example, for Japanese American women or, Caucasian American women, European women. You see it in Native American women and you see it in African American women.
And what about in the Hispanic, Latino?
It depends generationally.
Right.
Hispanic from other countries are doing fine or doing well, but by the time they've got a generation or two in, their daughters are at risk because they're American now.
Right. Right.
And the same with African born. It takes a generation and then we see the change. So one of the studies that was done showed that African-born women delivering in the States were similar to white women as far as birth outcomes.
Interesting.
Yes. But once they become Americanized, and it may be a combination of all kinds of things, and so much of this is intangible.
Right.
Right? But if you just, common sense dictates that there's a very strong correlation between the impact of racism, and it plays out through the body, through the emotional, psychological, through the social, through the spiritual. All of this is impacted, not just the physical. And these are things that we don't have enough science. Don't care how much research we do. We're not going to be able to address it and answer it that way because the same thing remains.
So looking for the solution there is not necessary. I mean, the science can't.
It helps.
But it can't qualify it enough to give us the answer.
No, because it's the human development of a new way of being and the new way of thinking. I think younger generation, they are doing really well. There's so much more inter-relationship, and they don't necessarily see the same way that we do. But it's a long haul because it's institutionalized.
Yeah, absolutely.
How do you break down those bastions?
So how do we break down? Because I know that you've been working on this, like you said, almost from the very beginning of you getting to this country.
Yes.
Which I remember hearing you speak one time, and you talked about how you crossed the pond.
Yes.
You got off the airplane and it was like, wait a minute. I thought I just crossed a pond.
Yes.
That's all I did.
Yeah, like a body of water.
Yeah.
Yet, in fact.
But it was like going into a whole different world.
Yes.
So you didn't feel that in England where you were brought up?
No, I felt racism in England. I felt that you feel racism. I've traveled and it's all over the world. Okay. There's a very different kind of deeper, more insidious racism here that maybe we'll never be able to quite measure it, but we can see that the effects of it are very clear. This is what we have because of the policies that continue and the ways that we implement and put in place the things that we say are okay. We will all join in and we will all condone. Other than the wild revolutionaries, right? Right. But the general masses, we will go with. We'll accept that a school will be put this way in this neighborhood with these resources from the same taxpayer pool. We will accept that.
Right.
We will accept that this library will only have these few books versus this massive gargantuan edifice here downtown, which is gorgeous. We will accept that because we don't even know where to start.
Right.
We don't know what do you do first? Which one do you take on first? So to answer your question, what do we do? Inside of our little world, our little circle of influence, I think in terms of birth work, we at least acknowledge that the disparity is there.
Yes.
And we speak the truth. In every other aspect of a maternity world, perinatal world, we speak the truth. We advocate. We stand up and we say no more. In every other aspect. And I don't understand why we can't do the same thing for disparities.
I was saying to ToRAISE before you guys got here that I grew up in a household. My grandmother was a civil rights activist, and she marched alongside Martin Luther King and was arrested at multiple locations throughout the South with her African-American best friend and their children put in jails across the country. Mm-hmm. And I grew up in a household knowing that this was our responsibility. It wasn't someone else's problem, that we really had to stand up and fight with everyone else. And so being within birth work has been, my platform so far.
Yes.
And I love that you just, I attended your training yesterday, and thinking outside the box really spoke to me, that all of these problems are and have been contained in this box. And so that was my, it was a hard workshop, hard training to attend.
And it's hard to stay in the seat.
Yeah. It was intense.
Yes.
So many feelings came out. Mm-hmm. And that glimmer of hope was thinking outside the box.
We also had the pleasure at Birth Matters of hosting Claudia Booker as our 2015 Advocate of the Year, and we had the pleasure of hearing her speak last Sunday evening. And one thing she said which resonated so strongly, and it actually resonated very strongly with my husband, who brought it up to me that evening, when she said, "Ain't nobody else coming. Ain't nobody else coming. No one else is going to show up and take care of the work." So just as Melanie said, I just want to echo that. Ain't nobody else coming.
I think that birth workers, we're a unique breed. We have such deep passion. We'll fight for that baby, fight for that mother, and understanding the fight, understanding what we're up against. We take the time. We share, we talk, we read, we listen, we go to our trainings. We're always looking for more information so we can fight better, fight harder. Well, if we don't know about what's really happening to a certain race inside of birth work, Black people have babies. Native women have babies. Everybody's in the same boat when it comes to maternity. But if we choose to not learn, understand, and embrace that same fight, then we're being disingenuous.
I think that's the message that is so clear to me about, and just so our listeners know that Jennie held a workshop yesterday here in Richmond that was really profound in many, many ways. It just brought this topic very much into, that's all we talked about for 8 hours. And it was very intense, like Melanie said. But we have to keep learning this.
Yes.
And we have to keep addressing.
And just so everyone knows, also, the name of the workshop was the Maternal Child Health Specialist Workshop, which I'll let Jennie talk about, but that if they are looking to bring this information to their community, it's a fabulous forum for that.
Right.
Well, thank you. And I want to, I called it Maternal Child Health Specialist on purpose.
Right. I like that. I liked your purposeful way of presenting it to us as well.
Because this is a piece that adds to the specialty or whatever your discipline is, whether it is education or clinical work or social work or whatever you're doing around women and children, that we have our own credentials, yes, But this is an area where we could specialize if we're really invested in maternal child health. I actually had one person one time tell me, oh, well, you can't call it that because, I've researched and, there are people with master's degrees that don't have this specialty and you can't. And I was really upset and hurt by that. But that was another example to me of the layers of unconscious bias.
Right.
What she was really saying was, well, how dare you come up with a title around this work that doesn't fit in with the mainstream, right? Mm-hmm. And I felt like saying, well, actually, the real specialist is the mother. How about that for some mess? Let's start with getting real. But that kind of stuff, we do this as humans. We judge and we want to do one-upmanship and we want to, you need to get back in your place and all of these things come up. But it doesn't take away from the fact that, whatever you call it, it's work. And everybody worked. I could tell everybody was working, but I was so grateful that everyone stayed in the seats.
Right.
And the conversations were courageous.
They were. And they weren't always easy.
No.
Additionally, as I was doing some recruitment to fill the seats, what I found was that when I called the professionals, they seemed a bit dismissive, as in, oh, no, I already get it. No, it's just, I would say, Jennie's offering the maternal child health specialist training, and it's going to be fabulous, and it's enrichment. Oh, well, I'm a licensed clinical social worker. I got it. Well, there was room for every person in that room to grow, and I cannot imagine one single person. I mean, bring me Michelle Obama. I mean, bring me whomever. Bring me Hillary Clinton. Bring me strong women. No matter how brilliant you are, you will learn something from this training.
I agree. And we had such an eclectic group of women in that, and I should say people, because we did have a man there as well, who came from all professional and professional. Everybody was a professional.
But a nice, diverse representation.
Yes.
I think it was typically, the full perinatal spectrum.
Yes.
And that was very helpful to have that audience and to have their ear. I think that we when we ask what can we do, if we are brave and strong and we say, okay, we can listen, we'll start by listening to each other better so we can work as partners and we can listen to the women. So we need to have access to their voice and hear what they need to tell us, and then we can craft how we can support.
And I think, you know what, Jennie, it's really, I'm going to be so honest, sometimes the listening to some of the young women that were attending the workshop who are African American was hard to hear. And my ears wanted to create defense.
Yes.
I wanted to be defensive, and I felt on the defense at times, to be totally honest, because I'm not a woman of color. I am a 58-year-old woman who is Caucasian, who has lived a life of struggle, but virtually a lower middle class life. So I can appreciate my struggles, and I believe that I am a person who wants to meet a person where they are, and let me listen to what you have to say so I can understand you better. But I felt like put on the spot at times to acknowledge that. And I know this about myself. I already know I don't understand.
Yes.
I already understand that I don't understand.
Yes.
But I don't know how to communicate that with a woman of color without sounding condescending.
Yes.
And without also, to be totally honest, there was a moment, I had roller coaster rides, like I think so many people do, or did, of feeling like, oh, we're screwed. Like, this is just, how's this ever going to end? To, oh my God, look what she is doing. Look at what they're doing. Oh my God, I didn't know that. We have these resources. And then, though, feeling somewhat like, but I'm white. And I know that we gravitate more towards the people who look more like us, that
That's
we
right.
can listen to the message more through the ears of, we listen more through that lens.
Yes.
So that I kind of felt also like, well, what can I do? I'm just that white woman that, am I just a token white woman saying I believe in this and I want change?
It's very deep, but you've just literally done what you can do.
Yeah.
It's about being honest and authentic and acknowledging those feelings are there. You would take on and personalize those feelings that people express their pain or their angst and their sharing, and personalize it. And that's what happens with this institutionalization of racism.
Right.
And it's something that then you take on a personal feeling. Maybe it's a guilt or a shame or a frustration, but that then stops you from being able just to hear that other person.
Which is not what I want.
Of course not. And especially if they're expressing anger, then just like anybody, none of us like confrontation, or we don't want to be in a fight, or, so we all have our own ways of behaving when we are confronted.
Exactly.
And so this is how the barriers remain.
Yes.
While we bring it back to personal, oh my gosh, but I'm not that, or I didn't do, or it's not my fault, not my father didn't do, I can't be responsible for my grandparents. All of that then allows us to not hear each other and just deal with what's there. So we can then retreat back into, I'm caught up in my stuff, so the ears are blocked, just like you said.
Right.
But you expressing that allows all of those that couldn't express or wouldn't even think that through to hear it from you. And as you said, you hear it from your own kind so much easier.
Right.
So, ToRAISE has mentioned that she felt that way. I felt the same, but I didn't want to say anything. Or I just didn't know what to do with that feeling, so I just retreated and so we get to an impasse.
Right.
So the bravery of the women that speak and the sacrifice that it is for them to speak, because it's more pain, it's more stress, it's more angst, but it's also the same for those hearing it.
Right.
You have to be brave to just really hear it
and
not get your stuff in the middle of it.
That's it.
That's the bravery, your end.
Well, you said it yesterday so clearly, something that resonates so deeply with me, which is we got to come from the heart.
Yeah, that's all we have.
That's all we have.
That's what we have in common.
That's it.
That's where we can start. That's why we love birth work.
Exactly.
Those hormones, oh my gosh.
Yeah. But I mean, it is coming from the heart. And that's what I kept saying to myself, like,
bring it back there.
Yeah, bring it back here. And that's where I believe in that message of meet the person where they are.
Right.
Because then I can listen.
But also, you be met where you are.
That's true too.
Right?
Right.
We know what you all, and I say you all like you all white people, you all are having to contend with. We know. We can't fix it any better than, so it's a two-way street.
Right.
Here. So let's at least have the dialogue.
And I appreciate what you just said, because I think that I don't know that.
That's the learning.
Yes.
And that's the circumventing.
Because it can get stuck in the anger and the defenses and the offenses, and then nobody is dialoguing.
No.
And I think, ToRAISE, we had this conversation a little bit yesterday, and I've been continuing to have this conversation myself. And I think for me, the point is that discomfort feeling is not something that happens to me very often. And so when I'm uncomfortable and when I feel defensive and when I feel someone is angry at me because of the color of my skin, I think, I only have to that's not the right word. I only have to manage that occasionally. What must it be like to manage that every day, all day, until I go to sleep? So I keep trying to come back to those feelings of I'm privileged most of the time.
Yeah, it's a good way of looking at it, because if you consider that we see the result of it, having to deal with it all day, every day. And by the way, it doesn't stop when you go to sleep, sadly. It continues. There's this, I think in one of the snippets of the film that we watched, the young lady mentioned that she can't sleep anymore.
Exactly.
Because she lost her baby to SIDS.
Right.
And she's watching all of the family members to make sure they're still breathing.
And if you don't live in a safe environment, which some people don't under these circumstances, you can't sleep in that way either.
Or even if you were just had a little slight at work, a coworker, your boss, somebody gave you that certain, there's a look, or there's a way of being, a way of holding yourself, which without expressing anything at all says, volumes.
Right.
When you have those little microaggressions, as we call them, consistently, we can tell, even if we just stay inside of our birth world, we can tell because the baby comes out at 28 weeks instead of 38.
Right.
The baby weighs 4.5 pounds instead of 7.5 pounds. Right? We can see it. It does manifest itself.
Well, the film talked about, and I believe you embrace this terminology as well. I thought it was a great word, toxic stress. It is. It's toxic.
It is. And that's a great, and I love your analogy of when you feel it every now and again, you recognize it for what it is and you manage it. And those are skills.
Right.
After a while, you lose skills, if you even had them in the first place, to manage it, recognize it. I did a workshop 2 days before I came, and a woman in that workshop, a white woman, asked the question, well, what about the men? They need to be accountable. We just don't think it's right that the men aren't accountable. And we were talking about low-income families having babies, and these were women who were in public health. And she was asking that question from a genuine place. She feels like the fathers should have accountability. I think we all agree. We all agree that every couple should be able to, jointly manage the newborn and so on. But it was also that question was formed from that place that normal is that obviously the guys don't care, that they're not willing to be accountable.
Right.
That's normal.
Right.
From her place, that's the baseline. And we teased out, well, let's look at why it looks like men aren't accountable, low income, men of color. Why aren't they? Why does it look like? Well, it looks like that because many of them are incarcerated. Many of them are walking with records. They are unemployable. One of the starkest contrasts for me getting off a plane was I left a socialized country. When men are unemployed in England, they can sign on to benefits so that they can feed their family.
Right.
And yes, I'm sure there's many a charlatan, but the majority of them actually need to feed their family.
Exactly.
So when I got here and I was educated to the fact that men who are unemployed are out of luck.
Yep.
Literally.
Yep.
Then my first question became, how on earth can you manage? So women, on the other hand, can be supported, and particularly when they're expecting or mothering. Well, if men cannot be,
can we hold them accountable?
What on earth are we doing?
Right.
So these are historical barriers. These are men or boys of fathers who came back from a war that were unable, a war where they were fighting for equality.
Right.
And fighting against discrimination and racism, came back to a country where they were made sure that they weren't going to be able to buy housing in certain areas, weren't able to get mortgages, weren't able to get employment. That was part of policy. And prior to that, they were, Jim Crow laws that it's on and on. So you go back all the generations, men are not unaccountable or not able to be accountable. They're not able to parent, which is the different baseline.
Yeah.
So, if you keep digging down, you come back to this place where you understand this is very, very institutionalized. It's insidious. It's very deep.
And you mentioned, Jennie, yesterday some tiny things, some little things that people can do one-on-one. Did you?
Yeah. I mean, I think it's important to just try to choose something that will have you achieve something on the other end, so you can say that you've made an effort and you feel better. And you work then on yourself from the angle of, that's one little piece I've done, and so I will at least acknowledge that to myself and feel okay about that, because you can't take on the major. But you can manage yourself, like you said, and I like that. That's a great expression. So, for example, in our world where we're working with women, working with families, if we recognize that it's on us, the onus is on us to find a way to be outside of that box.
Right.
It might be that you bump up with someone in the same grocery line. You may be able to have a comment that's positive and encouraging.
Exactly.
Rather than do that look that, oh my gosh, look at these children, oh, any of that stuff.
Right.
That it doesn't seem like a really big deal in your everyday world, but has an impact.
Oh, and we've all had the experience
Yes.
of being looked at or something said to us, just
Yes.
like you were bringing up, Peggy, in our life
Yes.
and how it makes us feel.
Yes.
The conversation that happens then in our head, and I don't think I'm that unique, it plays over
Yes.
and over
Yes.
in my head.
Yes, it does.
It's like this
Yes.
ongoing tape
Yes.
that reminds me,
Yes.
or something else happens and it pushes that button again of play.
So if you have the button pushed consistently,
Right.
or the accelerator being pressed consistently, eventually there's a snap, a burnout, there's something triggers that, final assault. That was the last straw, and everybody loses it. So it's about being mindful, so that you are not perpetuating ways of being around people of color that add to that burden.
Oh, and go ahead. It's just, it's so complex, everything we're talking about. And yet, you just said it. I mean, that's the simplicity of this, and not to take away from the complexity of it. But it's that,
Yes.
it's really the golden rule. It's
Isn't
treating
it?
people
Like you'd like to be treated? Yeah.
And
Like every time?
every time, and suspending judgment, because I don't want to be judged.
No,
so
nobody
how
does.
dare I judge somebody?
Right.
I want to be treated well. I want somebody to guide me when I
Right.
don't know what's available to me
Yes.
out there, and that's that compassion.
Yes.
That compassion of
Right.
coming right from your heart.
Right. But when you block that compassion with, I don't feel right, and I'm feeling embarrassed, I don't know if I'm going to be, all that stuff,
Gets in the way.
it's in the way, but it's stuff that you could actually remove.
Yeah.
So the will piece comes in there. So is there a will to manage that stuff for the better outcome? It's not about rushing in. Many women ask me, or people ask me, well, I just can't go into that neighborhood because I'm not going to be accepted. By the time you get yourself all caught up there, you've completely derailed the intention. The intention that you had to do something that was positive and supportive for women who are having babies. Having a baby. It's not just, I'm going down to get my, my blood pressure checked. Having a baby, like creating life that will perpetuate lines of people, what we would want for ourselves, the golden rule thinking around that. That's what drives birth work.
Yes. Yes. And
Isn't it?
Yeah, I think everybody who's listening, that's what I would hope that's what drives them, not the money aspect of
Right.
it, but
Providing support.
Support. And women have done that historically, they've done that organically, Indigenous women, we all have done this. It's like when there's a disaster, a natural disaster, a hurricane or an earthquake, suddenly race disappears because we're all in it together. We're humans now.
Right.
We don't have time for all the silliness that's in here blocking. That's gone. Poof. We dig in and work together. But after the disaster, let's just retreat back.
To our ways.
To our ways.
To our separate
Yes.
corners and our
Yes.
separate lives.
Separate ways. So it is our choice. And this is where we have some power we decide, are we going to check our privilege? Are we going to explore for ourselves our individual ways of being around this and see if there's a way we can change or practice? You can fall down 100 times, do it wrong. So try again.
Yeah,
Can
that's
we raise
a very valid point.
Yeah. Can we raise our children with some idea and perspective around it? Because we do raise our children to know certain things. Don't go here. Don't do this. We don't want the other. And that's based in that complete acceptance of how we've set this society up.
Yeah, because we base it on, we're here to protect you and keep you safe.
We do, but actually underneath of that...
Oh, I know that. I know, and then the interesting thing is, those don't go there places, that's what those people want as well.
Yes.
Is to keep their families safe, and their children safe.
Yes, but if you never have an opportunity to get out of, it's not about pulling yourself up by your bootstraps will not help you. The system has been created to make sure you can't pull yourself up by your bootstraps.
So in your community, I know, but the listeners may not know, your Access Clinic and your birth center has really had a profound effect on now going into probably a second generation almost of you're probably seeing grandbabies coming in.
Yes.
So tell us a little bit about what you how your system is set up and what the results have been, because you have actual numbers to support it besides anecdotal, which I love anecdotal.
Me too. Well, I have 4 tenets that are really the key to this model: access, connections, knowledge, and empowerment. The access piece was very simple. Just make sure that no one gets turned away, period. Like, they show up and they have a reason to be there. Usually being pregnant is the reason. We're good, let's go. And we'll do the troubleshooting on the other side. So the troubleshooting of, do you have insurance? Do you have Medicaid? Do you have money? Do you have food? Are you okay? What's going on? So bringing a patient into the clinic, regardless of her socioeconomic status, her insurance status, or any status, even citizenship, we don't care, you will get seen. We did that because I felt like, the National Health Service is deep in me. That's what I left in England. Everybody gets access to healthcare. So I said, let's do that.
What a marvelous idea.
I know. So that opened up the door, though, for the community to say, go over there. You're going to get in. You're okay. And so the word of mouth built the clinic very quickly.
And was word of mouth intentional, or was it just truly the women who were coming in there were going back?
They were the ones.
Yeah,
they took the message. I didn't know, because we wanted to provide birth center services, obviously, as a birth center. And again, having to let go of being the one to deliver the baby was the big key for the population that started coming.
Tell us, I love your way of saying letting go of the... You use another phrase of it.
All various phases, but one of them, is getting all caught up at the perineum. Like, we gotta be, that's, we live and die around that. And yet that's just one minuscule piece.
Exactly. So
and
go ahead.
Women going to deliver where they choose to be, where they feel safe, is really the most paramount reason that we do this work. Because when they were asked, no, I want an epidural. Okay, fine. I don't particularly condone that, but that's their choice.
Right.
That's what has women feel safe. And you don't know why she needs to be numb.
Right.
You don't have a clue
exactly
what's going on in her world.
I've talked about that many times.
So the women were able to get access, and therefore they were then comfortable. They trusted us, and they opened up with, what do I need to know? So once there was an access piece, then the connection was in place, and then the knowledge was imparted, following up with the empowerment. And that was for the father, the siblings, the neighbors, anybody. So we're doing our version of public health outreach, but in our center. The community comes to us, we do what we can, what they've asked for, and we duly send them on their way.
So just to be clear, so do you see them prenatally, and then you have a relationship with the local hospital to deliver their babies?
Yes.
So all of their prenatal appointments are with you?
Yes, and then the hospital delivers with the resident training program, which women are not that bothered about. They know that they're going to get a 5-minute wander at the foot of the bed.
And
So they're not
prepared.
bothered. They're ready.
They've been prepared.
The nurses are their friends. They love the nurses. The nurses know what we're doing and they support our practice. So they could care who's passing through that last 5 minutes of pushing. Seriously. And then postpartally they come back, and then we try to provide some postpartum support. We're not very successful, and we don't see the same numbers coming back. And we are now opening a women's health clinic to add to that, to make sure that there's some access in between the babies.
Yeah, that's so important.
Right.
And correct me if I'm wrong, Jennie, and ToRAISE, if this is not what you want, but it's my understanding that for many of the women that you see, you're actually not getting any payment. And so if folks wanted to make a contribution to the nonprofit Common Sense Childbirth, that would be very appropriate.
And we'll put information on the Facebook page about this so that people know. Because, this is totally being done not as a huge profit-making experience, as Jennie will tell you, which is why she's out on the road speaking a lot as well. So going back to those tenets.
Yes, so the 4 access, connection, knowledge, and empowerment have translated, and without us planning, we realized we should start counting our outcomes to see what we were getting, and without us setting out to do it this way, but it turned into, look, these women are going to term. These women are having healthy weight babies, and these women are breastfeeding. And this is the group of women who are historically at risk for the low birth weight, premature, and poor outcome. So we did a comparison study of 100 of the women. We enrolled them prospectively. We waited to see what happened. And it came back exactly that. But most important of all, it was a mixed race group of women, and not one African American or Hispanic woman had a low birth weight or premature infant out of the 100. Unprecedented.
And yet, in the county that you are, and you could compare it to.
That year, when we did the study, there was a 19% for the state of Florida, 21% for our county.
Of
low birth weight, of premature infants for Black women specifically.
Isn't that crazy?
About 15% for Hispanic women. So Florida has a high prematurity rate across all races. It's outrageous. But in that one instance, and it was a small study, only 100 women in the study, 0% is a whole different number.
It is.
When you put it up against 19 or 20.
And it
wasn't 15 or 12. It was 0.
And as you made really clear, so I want to make it clear, we're using the words percent, but we're talking babies.
These are actual babies. And when we look at it another way, we've got our 2015 stats recently tallied, and we saw nearly 600 women through the Easy Access Clinic.
In 2015?
In 2015.
Wow.
So we're happy with that. It's a great number, except for we're still the same skeleton crew that we always were. But what we see is that, and we couldn't capture all the outcomes because so much moving, people are out of state, or they go somewhere else, because we start them and we say, wherever you want to end up is fine, just let's get you started. So once some of them get their insurance, for example, they will go find an obstetrician, which is, again, their choice. Right? And we don't argue. As long as you're getting care, right?
Exactly.
So, but what we did know, of the ones that we could capture, there were about 250 that we had outcomes for. And last year, 2014, I'm sorry, we're in 15 now.
Yeah.
I apologize, 2014. We had 2 premature babies. One was 32 weeks, one was 28 weeks. African American and Hispanic. But that's it.
That's it.
Wow.
Now, there may be others of the groups that have left us that we didn't have stats for them.
Which I would also say, I hate to. We don't know.
Right.
But had they stayed,
yes,
who knows what their outcome would have been. It could have been very, very positive.
Yes, because what we've seen as well, where the biggest impact is in the beginning. Right. The minute a woman trusts that you've got her best interest at heart, she'll do anything. So the behavior changes that we're looking for, the nutrition changes, that we've already got that in place, whether she runs off to Dr. Joe Blow at 32 weeks or not.
Right.
She got the base work. She got the education. She got the one-on-one. She got an opportunity to share her fears and concerns, and she got the opportunity to ask, what can I do?
Right.
Once you've got that covered,
Right.
Doesn't matter. And there are women who just stop coming and stay home for any number of reasons that we don't know why, but I feel good about those women too. I feel like they're prepared now. And we know this with the actual delivery stats, because our C-section rate is down at 25% in an area where 35, 40, 45 is normal.
Right.
This cohort of women, this demographic, if they can turn the C-section rate down by 10 points on their own,
right,
then they know how to handle themselves. And I think it's from the little support that they get when they come through.
So can you describe just briefly how the support is given? Because I think it's a model.
Yes.
When quite a few years ago when I heard you speak, I had an obstetrician sitting next to me who is a very great thinking obstetrician, and she leaned over to me and she said, "Oh my God, these statistics, whatever they are doing, we have got to be doing the same thing." She said, because we don't have these statistics.
Right. Well, we start with the front door even. You come in the door and it's warm. It's an inviting environment. It's not clinical or, stark.
But you're not in a housey...
No, we're not in a frou-frou.
Right.
No, we're not in the cottage.
Yes.
No.
Which is lovely. But
yeah, nothing wrong with the cottage, but, it doesn't appeal. No, we've got a very professional aspect. We have an elevator and you come upstairs and it's an executive building and you could be going to see the doctor or the accountant, that is that aspect.
Right.
But you enter the space, we do lavender and we try to have it be, it's different. But we also have a receptionist who will smile. She will smile because that's her job. She has to look up. She has to acknowledge. Doesn't matter how busy she is. You're standing there. She has to greet you and by name if she can.
I think when you bring this up, Jennie, I want everyone to really pay attention to that, because I feel like that is the beginning.
That is where it starts.
How you are treated when you walk in that door.
Exactly.
It's the worst feeling when you're not acknowledged, when you're standing there, or they get gruff with you, or they're just not kind.
Yes. That could actually be the difference between life and death.
And I bet people are thinking now, but yes.
Yes. I'm here to tell you. And that's why the position, when we hire for that position, and we've had a couple of times where we've had women that just couldn't work on my desk because I can't have the on again, off again. It's 100% of the time or you're out. We cannot be at my desk with that look. And we all know the look.
Mm-hmm. Yes.
So you can't. And if I catch you or if someone tells me, oh no.
I know a good care provider in our community where that's been the greatest complaint is how they're treated when they come into the office by the staff, by the desk.
But you can't get past them.
No, and they don't want to come back to this really good care provider
because
of those people who they first meet there. They're like, I don't want to go back.
And see, that's where you can see another example of systematic craziness, because most likely where you have these instances, and they are rife, many of the providers are darlings, but they're back there and they don't have a clue. And they don't have a clue from the point of view of not realizing that that's part of their work.
Exactly.
That's the piece that can be fixed. But it's such a disconnect.
It is a disconnect.
And that's something that people who feel empowered can do something about. And what I mean by that is if they had a bad experience, many others have had a bad experience. And if those who have a bad experience feel that they can write a letter, make a complaint, perhaps that person will get replaced, say exactly what they would like to have happen, then they could potentially find a person who would be more open to everyone.
Right. So it has to come from the hierarchical, individual practice, but that it's all the way to the top. So in other words, I talk about the culture of the workplace. So our culture is real easy, and we have all races in our practice. Poor white women are totally ignored in this country. Totally ignored.
I would agree.
Nobody is interested in them.
Nope.
Because their babies are reasonably sized for the most part, if they're not smoking. So whatever, right? But that's the shame. But what you need to look at, and a way to achieve this, is to create a culture and have everyone in the staff team buy in. And ours is, you're going to have a full-term baby. That's it. So whoever you are or whatever you bring, including your risk behavior or your risk from the clinical side of things or your status or your fear or your whatever you bring can be mitigated, because it doesn't matter which staff member you're in front of at any given minute, but we're all on the same page. You are going to have a full-term baby. And we say that and we impart that and we act that way. And then all of a sudden we see people joining in. Oh, okay. All right then. I never had one before. The numbers of women that have come through that have had previous preemies and they go to term and they're just incredulous. Some of them are even frustrated, like, can you get this baby out of me? I am 41 weeks. I can't do this. That's an issue we deal with more.
Right.
And so if you were to look and say, well, what is it? What piece? I think it's so intangible. We may never be able to really say categorically it's this piece. So the culture supports it. The way of being supports it. We find women I have women that we can't speak their language. Happy. We're not culturally competent in some of these languages. I don't have staff members who can speak to them. But we smile, we do our sign language, we giggle.
Right.
They'll find an interpreter or they'll manage, but we get there. And what are we speaking? What language? We're speaking love.
That's
we're
what
speaking
I was gonna
heart.
say. Yeah.
And we're speaking, you will have a term baby.
Yeah.
That language.
You're listening.
Yes.
You're listening even if you can't understand what's being said.
Mm-hmm.
And I think most of our ills in this country, both physical and emotional, would be healed if there was more listening in care.
Yes.
You're making that
Yes.
person feel like they're important.
Right.
And that their baby is important.
And that they're safe.
That's a very important one. And when you dismantle or attempt to dismantle racism, you have to remember that the same human tenets are there for all of us. And
Right.
we can have access to that if we just choose. You know how we can be about pets and animals and wrongdoing to animals? We're right there. It's not so hard to bring up and
Right.
evoke those emotions and ways of being around that. You know, little ones. I mean, as human beings, we have that capacity. So it's incumbent on us to do the work and not deny that the two pieces go together in all these instances. You can be kind, but you can be kind to this type of person and this one only. So you've got to choose, are you going to be universally kind and know why you're being universally kind? Because it's all part of the work. Otherwise you can then just fool yourself into, I got this, I'm good. Because no, you're not, because you're living in a society that says, actually, no, don't be this way, be this way. Because then you take it to the next level. Okay, well now, what's going on at my kid's school? You know, how's the brownie pack? You know, there's so many ways and so many next steps. So keeping it in context and don't allow it to be, well, I'm really kind and the world's best doula. I rub the back so well. But I haven't wanted to deal with this because it's uncomfortable.
Yeah. Discomfort.
Mm-hmm.
So in your office, you have the receptionist, who we just established is so, so important.
Yes.
And then
And she hands off to the supporters, either the volunteers or interns in our doula programs, our childbirth ed programs, and lactation ed programs. So they'll come in and get hours by hanging in my waiting room. And literally that's what they do, just hang out. There's no class, there's no formal anything. Either if there's a couple you want to sit and chat with, or one-on-one with a mom, or sometimes there's a little impromptu group, because some of the women will start talking to each other. Mm-hmm. So the doulas and educators, they are like the centering facilitators, except for there's no curriculum.
right.
We don't have a binder on the lap. We're not going through lesson one. We are just being, organically being. Someone says, oh, girl, these hemorrhoids. Okay, now let's talk hemorrhoids. And we roll. So it's very sort of as it happens, but it's real important to do it on a one-on-one basis. If people have private stuff to talk about, we can take them down the hall and talk private stuff. Mm-hmm. So it's while they're waiting and no one knows they're in class, on purpose. Then they go from there to the medical assistant, who is my strongest ally. My medical assistants really are much more instrumental to the delivery of care than any of our midwives. I mean, our midwives are great, But in the easy access clinic realm, the medical assistants are perfect, and they are African American, both of them. Right now, we do have a Spanish language practitioner. She's a midwife, but our relationship with the women is built in the what we call workup, when she's getting her blood pressure taken, when she's getting roomed, when she's what's going on, girl? What's the update? Oh, what happened?
Oh, I can only tell you, I've had a medical situation in my life in the last year or so, and I get taken into the room, and somebody is doing the blood pressure, doing all that stuff, and how I try to engage with those people, and there is no engagement.
They've been trained that way.
So, and yet with a lot of them, once I start asking, like, they take my blood pressure and nobody ever tells me what my blood pressure is. They don't tell me any, and I'll go, well, so what is my blood pressure? And some are real curt with me, like
how dare you?
And others are like interested that I'm interested.
Yes.
And I'll say, well, how's your day been going? And we start talking. But occasionally I get that person who already is that, and it feels so good to me.
Yes.
It just feels so like,
right.
Oh, they're not just here doing my blood pressure. They care about how I'm doing today.
Yes.
And do you need anything? You're probably going to have to sit in that waiting in the room for a while.
Do
you want some magazines or anything?
Yes.
Are there any magazines in here? Do you need anything?
Yes.
A whole different way of being treated.
Which actually, again, translates into life and death.
Exactly. And for me, it is life and death as well.
Yes. And from a clinical perspective, the practitioners train the medical assistants to be that way because of liability, because they believe, maybe wrongly, that those lower level credentials are not safe to be imparting medical information. I found the complete opposite. The patients disclose any and everything to the medical assistants. They depend on them for their break down the answer for me, like give me the real scoop on how I need to handle this. And by the time the midwife shows up with nothing to say.
Do you think it's because they're less intimidating?
Yeah.
I mean,
that's exactly why.
Yeah. They're
exactly
not
why.
the hierarchy.
Right.
They're more on their level.
So when a midwife, and most of the doulas and midwives, they spend a long time in conversation with patients, and they get this one-on-one. I know that's very important, but not for everybody. People appreciate in and out when it comes to, look, I don't really want to talk to you. So if I do what I have to do, I can do it in 5 minutes. And I'm out the door. And then she might go hang out some more in the nurse's office or down the hall with somebody, one of the doulas, and have the interactions where there's comfort. So it's not to say that they're not comfortable with the midwives, but that's not what they're there for.
Right.
So once you get over yourself and realize that you're actually just providing some care, and you're creating a space where this woman and her family get their needs met, not yours. You know how we are, the codependents among us, we just love all of that. Oh, I sat for an hour and we had this great conversation. And I'm like, what has that got to do with much of anything? Yeah, it's great to build relationship. And especially if you're delivering the baby, you better build some relationship, or if you're going to be a doula at that birth. But in this work, in what we're trying to achieve and the difference that we have achieved, we realized we need to change the paradigm. This is not the same way that we should be delivering care. Many women felt overly sort of like it was a little bit too close of a boundary that was crossed, sitting on a couch for half an hour holding hands. Mm-hmm. Like, her? Who? What? Who are you?
Yeah, who are you?
What are you up to?
Into my business.
What? Mm-hmm. So we have to work, and this is the cultural humility piece. This is the congruence with who are you? How can we serve? What's comfortable? What's good for you? What works for you? When your mother comes in and she's looking at, well, what on earth? This love fest. I mean, I thought my daughter needed some prenatal care. Like, there's boundaries and understanding of what's acceptable and what will lend trust and what will take away.
Well, it sounds to me like you've created this safe space for somebody to walk into, but you allow them to lead you instead of you leading them.
Right.
They're saying, they're really showing you the way of how they want to be treated.
Yes.
What they really find important to talk about.
Right.
And who they're going to talk about it with, instead of it being like, okay, well, now we're going to do this, and now we're going to do this, and you have to follow along. And that may not fit.
It doesn't Doesn't fit at all. And it's easy to get to that if you will just be open, remove that angst that comes up as you're listening, take the personal out of it, and commit to hearing from a space of, let's create a culture then that supports what you just said you needed. That's it. Mm-hmm. It's that simple. So it comes down to where there's a will, there's a way. Bottom line.
So
what I'm hearing you say, Jennie, is instead of the practitioner thinking, I'm going to show you how to have a healthy baby, mm-hmm. the practitioner is thinking, how can I support you to have a healthy baby?
Because believe it or not, actually, women know what they're doing. You know, yes. We're clear about that for other women.
Well, and, you know, it comes down to something I say a lot of, that I always need to hear. Everything I say, I need to hear myself say. So, is leaving your ego out of it.
Yes.
I mean, because our egos can really get in the way. I mean, they can be really beneficial to inform us of where we want to put our energy, mm-hmm. but then let it go so the energy just can happen without us getting in the way.
Well, and it is, again, I like that point, and I want to reiterate the choice around that.
Yeah.
Because we happily do that when we do our birth work. We don't have any trouble at all. For the most part. I mean, there's a few pathological people who
yes, there are.
You know, but the majority of us can do that very quickly.
Right. Get out of the way.
So when we choose to not do that, even though it's sort of subtle and we're not even aware that choice is going on, that's where we have to check ourselves.
Well, you know, Jennie, I just feel like I wish we could spend another couple of hours talking, but because you're just a wealth of information and insight into this really complex, that's the only word I can come up with, mm-hmm. Situation. But I feel like we have gained, everyone, in listening to you, of what really is important and how we do dismantle this in a way that we can actually do without. We don't have to save the world.
No, we can't.
We can't. But we can be all the things that you were talking about and acknowledge that. And I think the big point that I take to reiterate to everyone is acknowledge that this exists.
Yes.
That's the beginning.
Yes, let's start in reality.
Yes, not get stuck in, I don't think so, mm-hmm. or I don't want to know, or I can't know.
Or those women are bad and wrong.
Right, or that very significant, or that's their problem, that's mm-hmm. not mine, I can't handle that, I don't know what, no, somebody else is dealing with that.
Yes.
And we all fall into that. I am sure that even on your certain moments of your life, mm-hmm. you'd like to say, I'm done with this.
Yes.
I like mm-hmm. just catch those babies or go home and mm-hmm. have dinner by myself without everybody crowding me. But for everyone who might be interested to learn more about Jennie, she does have her actual business is Common Sense Childbirth. And is your website, commonsensechildbirth.org. Mm-hmm. Jennie is available to do trainings and talks. You just need to contact her about what that looks like, what's involved. But I will tell you, having had this real honor to be able to be with Jennie a couple different times through the years, and you stay in my mind, though. You stay in a really positive way. Your words are very significant to me through the years. I would highly recommend that this is something you consider trying to initiate in your community, to have Jennie come and speak to this issue, and to get healthcare professionals involved in listening to a person like Jennie, who can explain it in a way that I think that they can hear. I think you come from that really human and professional place where they have to listen. They have to. They can't say, she doesn't know. You do know. And so I just really want to thank you for being here with us. And
well, thank you. The honor is all mine to have the opportunity to be in dialogue with you and to know what your legacy is and what your contribution of all these years. And I see the juniors running and scurrying on, and I'm very impressed with what you started and how you stood for the women and the children over these years.
Well, thanks, Jenny. I think we're all in it for the same reason, like you said.
We are.
These babies are coming. Whether we think they should be coming into the world or not is irrelevant. They're coming, and we want them to be healthy.
Yes.
And we want their mamas to be healthy, and we want to have a good foundation for them to launch into parenthood with. And Peggy, thank you again so much for being here and for making this happen. And again, if anybody has any questions about Birth Matters, it's Birth Matters.
It's birthmatters.us.
It's different website than it was
different.
At one time.
It is. We've revamped the website. Yes. So if you haven't been there in a while, it's worth a visit. And we just really appreciate the opportunity to have brought Jennie here. We're so grateful for everyone's support in making it happen.
Yeah, so thanks.
Thanks for listening, everybody, and stay tuned to hear our tips from Peggy and Jennie. Okay, so we just like to finish up with a couple of tips, and you both have some good ones today. So, Jennie, what was your tip for us?
Well, one of my favorite ones is engaging the dads at the moment of birth. Just bringing dad to the bedside and supporting him, get his hand onto that warm, squishy baby. As mother's going skin to skin, so is dad. I think that's one of the easiest things to do and makes such a tremendous difference. It starts off on the right foot. So that's one of my tips.
Do you see a lot of partners helping catch the babies?
Not so much. There's, most of the women I work with are delivering in the hospital environment, so it's not that case. But birth center dads all day long.
Yes. Yeah. Good. And Peggy, what about you?
Sure. I'm also a doula, and as a doula, I recommend to other doulas to try to remember that every woman wants a safe and healthy baby. Just to keep that in mind as we're working with folks who may make different choices than we make. They are all in it for a safe delivery and a healthy baby.
I love that. Thank you so much. Thanks for being here.
Yeah, thanks both of you again.
Thanks for listening.